Hello everyone, do you know about Cubital Tunnel Syndrome?
The definition for the cubital tunnel syndrome is the ulnar nerve is injured in the cubital tunnel at the elbow, resulting in peripheral nerve compression syndrome. It causes the sufferer a great deal of pain and suffering, and it can even result in loss of hand function in severe case. Chronic irritation and pressure lesion characterize peripheral nerve compression disorder.
According to the population-based cohort studies, found that the proportion of general population, 5.9%, is identified with black criteria of cubital tunnel syndrome. Meanwhile, 1.8% is identified with street criteria of cubital tunnel syndrome. As for the incidence, estimated that around 24.7 to 800 cases mostly suggests that the adjusted incidence rate is 30. There are more men compared to women for having cubital tunnel syndrome. For the age range below 50 years, women is higher compared to men.
The etiology of the cubital tunnel syndromes include pressure. The direct pressure to the elbow can press the nerve and it can cause pain, numbness and muscle weakness, particularly to the ring and pinky fingers. Second is stretching of the ulnar nerve. So this can happen when someone bends their elbow for a long period of time and it can cause irritation to the nerve. Third is the anatomy of the ulnar nerve. Sometimes the ulnar nerve does not stay in its place and snaps back and forth over a bony bump as the elbow is moved, so that repeated snapping can irritate the nerve. Other than that, arthritis, bone spurs, and previous fractures or dislocation of the elbow can also cause cubital tunnel syndrome. And lastly, in many cases, the cause of cubital tunnel syndrome is unknown.
Next, we move on to clinical features. The first one is the patient may have the sign of ulnar neuropathy, which may cause pain, tingling, or numbness in one or both hands. The patient also may have glowing hand. Next, the patient may experience weak grip and clumsiness due to muscle weakness in the affected arm and hand. And last, aching pain on the inside of the elbow.
Elbow flexion plays strength on medial collateral ligament. The shape of cubital tunnel change from round to oval because the cubital tunnel rise during elbow flexion. Combination of shoulder adduction, elbow flexion, and wrist extension cause increased pressure in cubital tunnel with ulnar intraneural pressure increased 6 times about normal. Traction and excursion of ulnar nerve occur during elbow flexion.
Next, we move to the management of cubital tunnel syndrome. So, there are two types of management, which are conservative and surgical management. For conservative management, the most effective treatment for cubital tunnel syndrome is to stop the activity that is causing the problem. So, the patients are advised to rest and stop any activity that aggravates the condition, such as bending the elbow. Second, patient can wear a splint or foam elbow brace at night to limit the movement and to reduce the irritation. Third, patient can also use an elbow pad to protect against chronic irritation from hard surfaces. Other than that, patients can take non-steroidal anti-inflammatory drugs such as ibuprofen, naproxen, and celecoxib. They can also take steroid injections such as cortisone to help reduce swelling and pain. And lastly, patient can do nerve gliding exercise which helps stretch the ulnar nerve and encourage movement through the cubital tunnel. For surgical management, the patients can undergo endoscopic cubital tunnel release, which is a minimally invasive, promising and cutting-edge surgical technique. So the surgery is to reduce the pressure on the ulnar nerve by providing more space for the nerve to move freely and to increase blood flow to promote healing of the ulnar nerve. During surgery, firstly the surgeon will make a small needle incision over elbow joint. Then, a tools called retractors are passed through the incision to retract the superficially located nerve from the ulnar nerve. Then, a thin tube called an endoscope that has a camera attached to properly inspect the ulnar nerve and the surrounding structures. Next, the roof of the cubital tunnel is then divided to relieve pressure on the nerve. Lastly, if the nerve remains stable behind the elbow's bony bump during elbow movement after being assessed by the surgeon, the surgery will close with the stitches on the surgical incision.
Impairment and functional limitation according to ICF model. The structure shown the example of ICF model. From this structure, we are able to classify three components: impairment and functional limitation context, which are the factors below. Body function and structure impairment for the syndrome are abnormal claw posture, loss of hand sensation, clumsiness, weak hand grip, decreased oral numbness and tingling, specifically at 4th and 5th fingers. Functional limitation in activities are like carrying or lifting weight, unable to perform exercise, driving especially for long distance driving, and table work. Restriction in participation, for example like unable to engage in sports, travel with family, work, for example going for long distance trip.
For cause and prognosis, up to 50% of people get better with conservative non-surgical treatment. Prolonged compromise to the nerve can lead to complete loss of function. More pronounced ulnar nerve thickening at the time of the diagnosis is associated with poorer outcome at follow-up, especially in conservatively treated cases. The recurrence rate following surgical decompression is 12%. Conduction study signs of demyelination on testing usually indicate a favorable outcome.